recent pivotal randomized studies in this field of POEM compared to other treatment modality. And finally, we end with some recent advances. As many of you know that achalasia is a swallowing disorder characterized by the failure of a relaxation of our lower esophageal sphincter, the LES, together with an absence and or abnormal esophageal body peristalsis. And the patient will experience symptoms such as dysphagia, regurgitation, chest pain, and weight loss. And these symptoms are very distressing and significantly affect the patient's quality of life. The diagnosis for achalasia is usually started with endoscopy because to exclude organic obstructions. And for patients with achalasia, you will characterize by a dilated esophageal lumen with fluid retentions, but there's no mucosal diseases. And on barium swallow, you will see a characterized stricture at the lower end of the esophagus, which is regular compared to the irregular strictures for malignant diseases. And of course, nowadays, we make a diagnosis of achalasia by a high-resolution manometry, which is demonstrate the two cardinal features of achalasia, namely the absence of body peristalsis and elevated LES pressure. And with HRM, we actually can subclassify achalasia into type 1, type 2, and type 3. This is the treatment options. Conventionally, the two standard treatment options for achalasia is balloon dilatations and surgical myotomy. But certainly in the last decades, most attentions are into what we call peroral endoscopic myotomy, or we call POEM. The balloon dilatation have been around for many years. It's the most common procedure for achalasia, and usually is performed with endoscopy and thoracoscopic guidance. The advantage of balloon dilatation is this is a very simple procedure, relatively, and minimal invasive. However, the disadvantage of balloon dilatation is usually you require many type of occasion, multiple treatments, and the treatment itself is actually blinded, and there's a risk of perforation, which increase with subsequent repeated balloon dilatation. And surgical myotomy is the gold standard for treatment for achalasia. And this first started by Professor Ernst Haller, who first described the surgical myotomy for achalasia in the 1914. Now, this procedure has been around more than 100 years. And of course, nowadays, excuse me. Of course, nowadays we perform a laparoscopic way. And laparoscopic Haller myotomy is a standard. And as you can see from the video, this procedure actually is very nice to perform laparoscopically or robotically. And because you can see the G junction very clearly below the liver and at the hiatus. And the procedure usually is performed together with a fundoplication. And but nowadays, in the last 12 years, many people will are interested in this new technique called POEM, which is a lateral orifice surgery, because we perform actually a surgical procedure through our oral orifice. And the procedure is based on the concept of submucosal tunneling in the esophagus, and pioneered by Professor Inoue 12 years ago, when he performed started the series of POEM in Japan. And therefore, through his vigorous academic research and trainings, and this procedure really become very popular procedures around the world. The concept of POEM is based on this theory of what we call a submucosal space or submucosal endoscopy. This cartoon showed this concept. This is the wall of the GI tract. On the top is the mucosa, and it's surrounded by the bottom is by the muscle layer. And when you create a space in the submucosa, once you create a submucosal space, In fact, then you can perform any procedure, any surgery at the muscle layer. And once you close the mucosal defects, because of this mucosal flap, and they will have no full thickness perforation. And this is what we call a concept of a submucosal endoscopy. Techniques of POEM is essentially 4 major steps. First step is mucosal entry. The second step is submucosal tunneling inside the submucosal space, and you tunnel all the way to the gastric cardia. And then the third step is to perform the myotomy within the submucosal space. And once the myotomy completed, then you close the mucosal wound with mechanical clips. Just show you an example of a case of POEM for a case of sigmoid achalasia. This is one of our earliest case, early series. It was just performed to show that POEM can perform for cases of sigmoid achalasia as well. You can see that the esophagus was well tortuous with a tight GJ. The first step is a mucosal entry. Therefore, we lift up the mucosa with saline, with indigo carmine. And then we pick up using an endoscopic knife, we'll make a 2 centimeters incision on the mucosa. Then we'll insert our endoscope into the submucosal space and to create this submucosal tunnel. Here we are in the submucosal space. The one on the 3 o'clock is the muscle layer. The mucosa will be somewhere in the 9 o'clock positions. And you dissect the space close to the muscle layer to avoid any thermal injury to the mucosal layer. And you will encounter some blood vessel within the submucosal space. You can either divide it through the knife or with a coagulation forceps. We confirm that the submucosal space that we reach the cardia by this double endoscopy techniques that show that we have already created a tunnel all the way to the cardia. Once that you've done that, then you perform a myotomy and with endoscopic knives. Actually, very similar to what we perform laparoscopically or robotically. We can actually see the individual muscle layer, but this one is from the endoscopic view. And many of us will perform inner circular myotomy and try to leave the outer layer intact to prevent inadvertent injury to the mediastinum. And you can see that this one, you see that the end of the myotomy along the entire lower esophagus to up all the way to the gastric cardia. And finally, back to the esophageal lumen, then you close the mucosal defect with clips. And this is the end of the thing. This slide will summarize the advantages of a POEM from the AGA practice update. Basically, POEM provide the advantage, including there's no skin incision for our patients. The patient didn't require any abdominal surgery. They will avoid any potential problem of adhesions or nerve injury. The patient won't, because there's no fundoplication, they don't have any fundoplications issue, such as gas bloating. And POEM is actually a surgical myotomy. It's actually a myotomy, therefore it's a definitive treatment for achalasia. And you can apply to a patient even with a previous intervention because you are entering into a different surgical plane. And also for sigmoid esophagus. And more importantly, this procedure can also extend the myotomy proximally to as long as you to the proximal esophagus. There was it's a great treatment for patients with spastic achalasia or proximal esophageal motility disorder such as the DES or jackhammer esophagus. This is our experience since 2014. We have performed about 73 cases of POEM so far. And the pathology, you can see that there are a variety of, mainly for achalasia, mainly type 2, and some of them are type 3. And we also apply it for others, less common esophageal motility disorder. Duration of symptom varies from a week to 30 years. And 1/3 of the patients have previous treatment before, such as balloon or Botox or even surgical myotomy. We have about 7 patients have sigmoid esophagus. The average procedure time is about 129 minutes. and median hospital stay is about 3.6 days. This is our perioperative complication related to it. We have no conversion, no mortality, and no cases of leakage from the mucosal wound and the mediastinitis. But we do have some cases of pneumoperitoneum, which is treated by needle decompressions, surgical emphysema, one case of myocardial infarction after the operations, and one case of a pseudoaglasia. This is very important. Even though we do all the cases have done endoscopy and endoscopy and high resolution manometries and even CT scans, and we have to really exclude cases of pseudoaglasia, especially for older age patients. We have the most common complication we encounter is mucosal ischemia near the GE junction, and usually it is the tight area, tight space, but all the cases are managed conservatively. This is our result of our POEM in terms of efficacy. We measured it by the symptom, by the composite score called ERGAT score. The ERGAT score is a composite score composed of the dysphagia, regurgitations, and weight loss and chest pain. Therefore, you can see that from this graph that the preoperative ERGAT score in median is 6. We decreased in 1 year to 1. Therefore, our treatment success, as defined as ERGAT score less than 3 in 1 year, is the 91% in our series. This is a very recent summary of the results in the literatures. Summarize all the prospective series. As you can see, there's a series ranging from 32 patients to 233 patients. To highlight here is that I can see the efficacy rate is usually from 83 to 100%. Adverse event is also relatively uncommon, from 2% to 40%, depending on how you define as adverse events. Recently, there's 2 pivotal randomized studies have been published. The first one is a randomized study compare POEM versus pneumatic dilatation, balloon dilatation, where this study is a multi-center study from Europe and also Hong Kong. They randomized 130 patients newly diagnosed as achalasia into either POEM or balloon dilatations. The primary outcome of this study is efficacy at 2 years. As you can see, that POEM have the efficacy is 92%, which is significantly better than pneumatic dilation at 54%. In terms of adverse events, both procedures are relatively safe. There's 1 perforation, but there's 1 perforation for pneumatic dilatations. You can see that this is a serious complications. And there's also 1 mucosal tear in POEM. And but in terms of reflux esophagitis, the study also showed that POEM have a higher risk of reflux esophagitis. Most of them are LA grade A. I think these studies, Philip is one of the principal investigators for these studies. And this study showed that POEM is more effective compared to pneumatic dilatations. Next study is also a very recent study comparing endoscopic POEM versus surgical myotomy. And this is a study randomized 221 patients, 112 on POEM, and then 109 patients for laparoscopic halar myotomy with fundoplication, which is a gold standard treatment for achalasia. And this study design is a non-inferiority design because POEM is a less invasive procedure. As you can see that the primary outcome, you can see that this study is positive because it showed that both POEM and halar myotomy have the same efficacy and no difference in terms of efficacy. But in terms of adverse events, POEM is less compared to surgical myotomy. But again, this study also showed that POEM is associated with more risk, or higher risk of POEM compared to surgical myotomy. There were these landmark studies showed that the POEM is as effective as halar myotomy, but with less adverse events. Certainly, one of the main drive of this procedure is patients, because most patients prefer endoscopic treatment compared to a surgical procedure. And this is reflected in our practice in our own hospital. Therefore, you can see that this is a procedure for achalasia performed in our 10 years, in our last few years in our department. Usually we perform about 2 to 3 laparoscopic halar myotomy per year. But over the year, you can see the trend for surgical myotomy decrease, but the rate for patients who are choosing POEM significantly increased, more than tenfold. It's very rewarding to treat this patient with achalasia regardless what either surgical or medical or endoscopic myotomy, because these patients really suffer a lot by not eating. As an example from this newspaper articles is one of our older patients, and the patients finally can enjoy a decent meal after 30 years of achalasia. Some of the recent advances, as we mentioned, that one of the issue of a POEM is reflux. Therefore, Professor Inoue has developed this procedure for POEM plus F, or fundal pygations. And I think maybe Philip will talk a bit more about this procedure. As far as I know, I think the procedure are still evolving. And but this is certainly some good news for people that have a complication of reflux. And certainly the field of surgical submucosal endoscopy also expanded to other diseases, one such as gastric POEM for gastroparesis, or ZEC POEM for patient with Sanka diverticulum. And submucosal endoscopy can apply for patient for excision of submucosal tumor. We call it a POET, or a STIR, submucosal tunneling endoscopic resection, where I think Philip will talk about it in his lecture. Let's just show you a quick review, a quick video on a recent case of gastric POEM, what we call per-oral myotomy for patient with gastroparesis. Therefore, gastroparesis, the problem, we're using a similar techniques like POEM, but the target is in the pyloric muscle. Therefore, first we enter the submucosal space about 2 centimeters near the pylorus, and we lift up the mucosa with saline injection. Then we make a horizontal incisions. I'm sorry for the video. I don't know why, probably because of the transmissions. I apologize for that. But basically, we make a transverse incisions at the mucosa, just large enough for our endoscope. Large enough for our endoscope, and then we enlarge. Then we enlarge the space with further saline injections. Then our endoscope can enter into the submucosal space. Then we dissect the submucosal, create a submucosal tunnel, and we dissect the space until you see this pyloric muscle, which is on this 12 o'clock positions. Then we dissect it a little bit beyond the pylorus. And this is the true lumen. They can look at to confirm the location of pylorus. Then once you then after that we did a myotomy like the usual way using the endoscopic knife. So this procedure has been getting popular in the last few years around the world, and the result is also very encouraging. And once we finish the myotomy, I can see that this is the last layer of the pyloric muscle. Beyond that is the serosa. And this is at the end of the myotomy. And then we close the defects, the usual fraction with the endoscopic clips. Therefore, in summaries, ladies and gentlemen, POEM has evolved now to be a definitive treatment for achalasia, and now have actually level 1 robust evidence which confirmed that the POEM is effective and is also a safe treatment for achalasia. And POEM is especially indicated for patients with spastic achalasia and esophageal spasm, and also can apply for patients with recurrent achalasia with previous treatment, and also for patients with sigmoid esophagus. And certainly the field of POEM or submucosal endoscopy is evolving and is now applying to other diseases along the GI tract. With this, thank you so much for your attention, and I welcome any comments and questions.
Thank you very much, Professor Jimmy So, for the excellent lecture on the POEM. Very nice summary, and we know not only the technology, but also the science in the background and interesting outcome from all around the world. So perhaps I have one question for Jimmy. Very interesting, you showed the figure from National University Singapore that when you are practicing on laparoscopic cavalotomy, the number of cases in your center is in fact not a large number, but after you start the POEM practice, you can see a dramatic increase in the number of patients who have achalasia. So can you explain the reason why suddenly it seems that there's a rise in the trend and also the incidence of patients with achalasia?
Yeah, I think this phenomenon is also seen by many centers around the world who practice POEM. I think there's two reasons. One is because POEM is endoscopic procedures, so the patients will certainly prefer a center who perform this type of less invasive treatment. And secondly, because many of patients are undiagnosed, and the patients, because of the fear of surgical treatments or perforation from balloon dilatation, they defer their treatments and they live with it, because I think this is a chronic disease, and patient will find ways to accommodate the symptoms. And because of this fear, they tend to they don't seek for treatment. But once they heard that actually there's a less invasive treatment and is safe and is effective, and they come out for treatment. I think that's why I explained that the reason why that more and more patients, more achalasia patients come for treatment nowadays.
And there were some nice questions on the Q&A session. So maybe we can address some of it by live, and some of it I think Professor Jimmy So will type in the answer for you. I think we can select, for example, like one question asked the indication and contraindication of GPOEM.
GPOEM, it's still an early experience for us, and but so far our experience are very favorable. We basically we have to first confirm a diagnosis of gastroparesis, and nowadays most of us will use a nuclear scan, the gastric emptying scan, and with a normal endoscopy, which exclude malignant obstructions or other structural obstructions, and then in early in our series, usually we'll perform a trial of either Botox or balloon dilatations of the pylorus, just to make sure this is really a case of a pyloric spasm. But nowadays, I think many centers will offer a gastric POEM once they confirm there's a gastroparesis by endoscopy and gastric emptying scan. Therefore, I think it's important is to recognize that there is a confirmed gastroparesis. Yeah, then this is cases are indicate that will be suitable for gastric POEM.
Yeah. Okay. So I think I will leave the question so that Professor So can answer it on our Zoom by typing in, because it's time for the next lecture. So thank you very much, Jimmy. It's a very nice lecture. Thank you.
Thank you, Philip. Thank you.
Thank you. So next presentation should be by me. So okay, so I first share my screen. Okay, I think you can see my slides. Okay, so The next lecture is on the endoscopic treatment of GI neoplasia from ESD to EFTR. So I'm from the Chinese University of Hong Kong with several titles, so I'm currently working I'm also an upper GI surgeon and an endoscopist. So I think from what we know, currently from the global cancer statistics, you can see that the instance of cancer worldwide, commonest is lung cancer, breast cancer, and colorectal cancer. Stomach cancer is number 5, but if you count these stomach cancer and colorectal cancer as a whole, the number of percentage of cancers rate is 16% of all the cancer incidents. While if you look into the mortality, stomach cancer and also the colorectal cancer is among the second and the third most common. And we also know that from the different literature that the survival of gastric and colorectal cancer, it's depend on the stage of the diagnosis. So a lot of the time, when we are tackling with this cancer, the most important is how to make an early diagnosis. So if you can recognize early GI cancer, if they are locally situated without lymph node metastasis risk, then the treatment option is endoscopic resection. If there's a local regional disease with a high risk of lymph node metastasis, then we have to treat it by minimal access surgery. The advantage of endoscopic resection, including that this is not only a locally curative intent treatment, but we can preserve the organ so that the functional outcome of the patient is better and with a better quality of life. And it's also a better post-operative outcome with a shorter hospital stay and early return of GI function. In the past, we have already developed numerous methods to achieve endoscopic resection, ranging from polypectomy to EMR. EMR is specially developed to address the treatment of early GI cancer, pioneered by our Japanese colleague. When you look into the technique, it is a modification of the polypectomy with the application of a snare after injection, and also like this is a cap EMR. But the variation, there is a major variation in the recurrence rate locally. One of the reasons is because this technique will be adequate to treat lesions of 1 centimeter. But if for those lesions larger than 1 centimeter, we cannot resect it on block, and we have to separately resect it in piecemeal, and that leads to a higher risk of local recurrence. So that is the reason why our Japanese colleagues pioneer the performance of endoscopic submucosal dissection, or ESD. It can achieve a on-block resection for the local early GI cancer. It can also ensure a wide resection margin with a better specimen for histopathology, and also there may be some differences in the various parts of GI tract in applying this technique, but it can generally be applied for treatment of early GI cancer for the whole GI tract. So this is the first concept of ESD, and reported by Dr. Ono from Japan, and with the performance of a hybrid type of ESD, out of the 278 early gastric lesion, local recurrence rate is just 2%. And this is a short video to demonstrate the technique. Also, firstly, we mark around the lesion so that we'll be able to locate. And after the marking, then we inject a submucosal solution for to lift up the mucosa and to ensure that we have an adequate submucosal plane for dissection. And of course, with the current optical technology, with the use of the magnifying endoscopy, near focus, and also image enhanced endoscopy, we'll be able to recognize a good resection margin for this lesion. So this early gastric cancer is located at the upper part of the proximal body. So a lot of the time, the dissection will be performed in the retroflex position. So and you can see that after the injection, sometimes we will not be able to identify a good tumor margin. So that's why we have to mark around the lesion before the dissection. So, and then you can see that we are dissecting at the submucosa, And we are using this ESD device. This is called the dual knife with a water jet function. So when you are dissecting, you will be also able to inject at the submucosa. And during this dissection, a lot of time I would just open around 75% of the circumference before the completion of the submucosal dissection to avoid too much of the leaking effect of the submucosal cushion. So, some of the area I like to use the IT knife, so insulated tip knife, which is one of the most earliest type of the ESD device. So it has a ceramic tip to avoid diaphragmatic passage and allow a safe dissection. So, one of the difficulty of the submucosal dissection is that we do not have another arm or retraction device for us to lift up. So it depends on the cap, the scope, and the technique of the endoscopist to achieve a good lifting effect at the submucosa to avoid perforation. So this lesion happened to be over a previously dissected area, so over a previous ESD scar. So there may be some adhesion encountered during the dissection. So a lot of time we use the indigo carmine dye to inject at the submucosa so that we can have a better view and avoid a perforation as well. So this is the final part of the submucosal dissection. So after completion of the dissection, we have to re-examine the area and confirm the good hemostasis. So we would also use the coagulation grasper to coagulate any prominent vessel at the ESD site. So there has been meta-analysis comparing ESD versus EMR for treatment of early gastric cancer, showing that there is a significantly better on-block resection rate, lower recurrence rate. However, ESD ended up in a higher perforation and also bleeding. So how about the comparison between the ESD against laparoscopic gastrectomy? So at our unit, we have conducted a randomized control trial comparing ESD versus lap-assisted gastrectomy for treatment of early gastric cancer. So the results showing that the ESD can achieve a shorter operative time, shorter hospital stay, and early return of GI function, and the complication rate is also lower for ESD. And if you look into the post-op pain outcome, that the ESD have a significantly lower pain and also a lower level of CRP on post-op day 1 and day 3. And as I mentioned, one of the disadvantage of ESD is that unlike minimal invasive surgery, we do not have another arm. So we need to use one single arm attached to the scope for the dissection, which is quite difficult. So nowadays, there's been development of kind of retraction device using a dental floss and a clip, so that the dental floss or any suture can be tied to the clip, and the clip will be applied to the edge of the mucosa so that to enhance a retraction. And with this in a reported study, the dental floss group can have a shorter operative time as compared to the control without this retraction. And I think you probably also know that in collaboration with National University of Singapore and also Nanyang Technological University, we developed the robotic master technique for performance of the ESD. So this is a robotic system, and we conducted this clinical trial in India at the Hyderabad at Professor G. Rao's unit, and also at the Chinese University of Hong Kong. And with 5 patients with early gastric cancer, we can achieve a endoscopic submucosal dissection with the robotic system. So in the editorial published in the CGH in 2012, actually Professor Halls mentioned that in our report that robotic endoscopy, a small case series, a giant step for endoscopy. So the system has been improving. So this is a second generation of the EndoMaster EC system. So you can see that there's a well-developed robotic arm, and also a currently independently designed flexible endoscopic platform for the performance of robotic ESD. And after a few animal study, so currently this system is on an ongoing clinical trial at our unit for colorectal ESD. So as Professor Jimmy So mentioned that there is an increasing potential of therapeutic endoscopy. So we can say that this development is actually from the first to the second to the third phase. So you can see, as I mentioned, the very early stage of endoscopic resection is in fact from the concept of polypectomy in 1969. But over the past 40 years, I think there has been a significant improvement in the technology, show that with the development of EMR, ESD, and the concept of natural orifice transluminal endoscopic surgery, that comes to the second space. Now we recognize the third space, which is the submucosa, and with the POEM as a beginning. And this is reported in GIE by Professor Kashyap that if the lumen is historically first space and the peritoneal cavity is known to the endoscopist as a second, then the intramural space comes to represent the third space. So the concept of MIS and also the first space endoscopy, I think there may be some meeting place between the two technology. So I think Professor G.V. Rao will tell us more about that. But with the use of endoscopy over the first space, then we do not need to open up the abdomen with the incision, so that there will be minimal or no pain, there will be earlier recovery, and also no incision, no scar. So I guess next speaker, Professor Anthony Teo, will tell you more on how EUS can achieve those endoluminal intervention without any scar. So as Professor So mentioned about the first, the POEM being performed by Professor Inoue back in 2008. So the comparison between these two concepts, I think showing that we are achieving the same surgical procedure and also the outcome, but the POEM is without any incision. So, and there's been fast development in the first space endoscopy. So my talk will be focusing on the endoluminal treatment of GI neoplasia. So at the submucosa, then we are focusing on treatment of a subepithelial tumor. So with the concept of the POEM, we can actually pass the scope into the submucosa, and naturally we can encounter this submucosal tumor and treated them by endoscopic resection. So this is called a submucosal tunnel endoscopic resection, STIR, or a peroral endoscopic tumor resection, the POET. So same concept of endoscopic incision, afterwards dissection around the tumor, and thirdly is to resect and take out the tumor, and fourthly is to close the mucosal entrance with clips. So this is one of the diagram to show you the technique of this procedure. So very importantly, step one is to develop a submucosal tunnel. And usually the mucosal entrance is 2 centimeters above the submucosal tumor. And I also always dissect the tunnel around the tumor and reaching the distal part of the tumor. And I need to create a distal pocket so that to allow the manipulation of the submucosal tumor, and finally to take out the tumor from the mucosal entrance site. So this is one of the video to show you how we perform. So it is a esophageal leiomyoma, and we developed the submucosal tunnel 2 centimeters proximal to the tumor, and the same as the POEM. Then after dissection of the tunnel, we will be able to reach the submucosal tumor. And after reaching the submucosal tumor, we'll continue the dissection around the tumor, and to ensure that we have a good border of dissection. So this is the submucosal tumor while it is adherent to the muscularis propria layer. And further dissection will be performed around the tumor and to develop a tunnel in the two surrounding. So we used ordinary endoscopic instruments, including, as mentioned before, this is a dual nerve that I also use for performance of ESD. And then afterwards, I would generally also use a IT knife to perform the dissection. So, and you can see, so due to the limited space in the submucosal tunnel, sometimes manipulation of the tumor is quite difficult. So this is the dissection at the base of the tumor from the muscle layer. So as you can see here, so dissecting the tumor away from the muscle layer. Sometimes you need to take part of the muscle in order to get a reasonable margin for the resection. In the esophagus, most of these tumors are leiomyoma, so we are not too worried about the resection margin. But for a submucosal tumor in the stomach, a lot of the time these are GIST tumor. So we are more worried about a incomplete resection with a inadequate resection margin. So after a completion of the dissection, the final part is the most difficult part because most of the tumor is free from surrounding attachment, so making it difficult to manipulate. But finally, we can take this out from the mucosal entrance site, and then complete the mucosal closure by clips. This is our report in surgical endoscopy with 51 cases of peroral endoscopic tumor resection. The location of this tumor we selected to be in the gastric cardia, lesser curvature, and from esophagus, because these are the most difficult sites even for laparoscopic surgical resection. Size of the submucosal tumor is usually 20 mm, and the operative time is 90 minutes. So there are some cases that require conversion to laparoscopic surgery, like retrieval, because it is too large a size. And there are 3 cases that I need to convert to full fingers resection. And then there's also 2 cases that require a double entrance and extraction site. But as I mentioned, sometimes it is really worrying, especially in dissecting a GIST tumor, that in the submucosal tunnel resection, we may be breaching the capsule of the tumor, and failure to achieve an en bloc resection will end up in a recurrence for GIST tumor. So I think there are 2 ways to manage that. One is the laparoscopic endoscopic collaborative surgery, while the other is endoscopic full fingers resection. So EFTR has been developed since early 90s with the colorectal surgeon performing transanal endoscopic microsurgery with this TEO device. I think they are doing full fingers resection for early rectal cancer. And the concept is to perform full fingers and afterwards suturing the defect. I think currently it is indicated for mucosal neoplasia that with the dense submucosal fibrosis, making ESD not possible, and also for some mucosal tumor like a GIST tumor. But there are some relative contraindications. For example, if the tumor is too big, then we cannot retrieve it by per oral or per anal route, then this may sound irrelevant to do an endoscopic full fingers resection. And some location may be anatomical limitation, like in the esophagus. If you perform EFTR in a very large defect, sometimes difficult to close. The second is some position in the duodenum, especially in the medial wall. So just to illustrate the procedure step for gastric EFTR. So first, usually this location of the tumor is at the cardia or proximal body for GIST. So firstly, the scope will be placed in a retroflex position. We open up the inferior edge of the mucosa, and afterwards we dissect around the tumor, and with a submucosal muscular dissection for mobilization. And afterwards, we have to apply some retraction device like a clip and dental floss or suture, so that the tumor will be retrieved to the inside of the gastric lumen. So I'm always a believer that the flexible endoscopy performs the best inside the GI tract lumen. So we can achieve this by pulling the tumor to the inside of the gastric lumen, and afterwards we finish the dissection and retrieve the tumor per orally. So this is one of my procedure of EFTR for treatment of the gastric GIST. this gist is located over the gastric proximal body. So as I mentioned, firstly, I would open up the inferior mucosa that is very close to the submucosal tumor. We don't need to develop a tunnel, so we can directly open up the mucosa. And I usually open just half of the mucosa. And afterwards, I would dissect around the tumor. And as you can see, there are the muscularis propria. And because this is a GIST tumor, it can be arising from either side of the muscularis propria, with some component always adherent to the muscularis propria. So I'm pretty sure that we need a good dissection of the muscularis, and all the time ended up in full thickness incision. So I use both the dual knife and also the IT knife for the dissection. And as you can see here, so I also mobilize the tumor, and sometimes cutting the tumor to preserve some of the mucosa to enhance the closure. So this is now full thickness, as you can see. So after the full thickness incision, I always apply the creep and the suture technique. So one of the reasons is because I don't want to drop this tumor into the peritoneal cavity. So if I drop this, then it will be lost, and I need to search it. If I cannot search it, then I need to convert to laparoscopic surgery. So secondly is to pull the tumor to the inside of the stomach, so that I will be able to perform further dissection. So I apply the second. So usually two creep and the suture, and then I pull the tumor further inside. And now with the exposure of the GIST tumor, you can see this is a serosal surface, and they are always having a density of blood vessel over the serosa. But if you can see that, then that is the outside of the gastric wall, and I can pretty sure everybody can understand this is a tumor margin. So pretty sure and confirm that we are not cutting into the capsule, but protecting it. So this technique will enhance the en-bloc resection of the tumor. And afterwards, I would complete the dissection by using the IT knife. So, and most of the component then be retrieved inside the gastric lumen. So I can complete the dissection from the inside of the lumen. So this is the final part of the dissection. So with the use of the IT2 knife, so I can complete the resection. And then afterwards, I always take out the tumor first, so avoiding it dropping into the peritoneal cavity. So after taking out, I use the Apollo overstitch, which is an endoscopic suturing device for me to close the defect. So this is the older version of the double channel version of the Apollo overstitch. So you can see I can pass this needle in between the two arms, and then afterwards I would reload the needle and continue the suturing. So it can achieve a full thickness suturing, so of the two sides of the gastric luminal defect. And after the completion of the suture, we will tie tighten up the suture by using a casing. So now I just drop the needle, which acts as one of the end to pull the needle, while afterwards I will use a casing and tighten the suture. So I usually apply it as a figure of 8 manner for closure, and also I would perform 2 suture, not only 1, because of the safety issue. So, but then after the completion of the suturing, you can see a very definite closure and a good capsule. So if you have a small defect, so one of the methods to use is actually a creep and the loop crown suturing to close. And that's easier to apply, but it's a high demand for endoscopic skill and also need a careful planning. So generally I use a full overstitch, and it can be divided into single channel, and currently there's also a double channel and also a single channel version of this overstitch. So we have done more than 22 cases of this endoscopic full thickness resection. Operative time is 92 minutes. The size of the tumor is 21 mm. You can see that half of these cases require overstitch for closure, and most of these tumors are GIST tumor. So in summary, endoscopic treatment of GI neoplasia has extended from liminal ESD to submucosal resection of this tumor and also EFTR. I think in the future, advanced robotics will further enhance the development of endoluminal therapy for GI neoplasia. So with that, I hope to welcome everyone to join us, and I hope it will be a physical meeting for ELSA 2021 in Hong Kong. So thank you very much. So I can see that there may be some question in the so I have 5 minutes, so probably I can just answer one question. So there is a question about the difficulty, how difficult was finishing with the procedure after the not small gastric perforation. So in fact, the difficulty is the leak of the gas. If we are dissecting too big a size of the EFTR with a big hole in the stomach, it's sometimes difficult to achieve a good insufflation. So closure may be a problem. But if you think about the inclusion criteria, then most of these tumor will be less than 4 centimeter, because if it's bigger than 4 centimeter, it is difficult to be able to retrieve from perorally. So if you are doing just like a 3 centimeter or less than 3 of a tumor, the defect will be less than 3, because a lot of the component of this tumor is inside the stomach. So maybe the defect, if it's just 1 or 2 centimeter, then the whole the gas insufficient can be maintained, and it's not that difficult to close. Okay, I think because of the time, I have to continue this webinar. So welcome our next speaker, which is Professor Anthony Teo, and my colleague who is also working in the same unit at the Chinese University of Hong Kong, and also he's a surgeon and endoscopist, and he specialized in the EUS. And so Anthony is going to tell us about interventional EUS from practical to extreme. Anthony, please.
Thank you, Philip, for your kind introduction. So my topic is on interventional EUS from practical to extreme. So I'll be going through various developments on EUS interventional procedures. So these are my disclosures. So in the past few years, in fact, we have seen a very quick development in different kinds of EUS guided drainage procedures. In fact, I would describe it as a festival, because almost every year or every few months, there will be a new procedure that is being described. So nowadays, we can perform easily bowel duct drainages. And after bowel duct drainages, the stent can be used as a portal to allow the scope to go into the bowel ducts as well. Gallbladder drainage, we are doing a lot of studies on gallbladder drainage. Again, after gallbladder drainage, the gallbladder is now in the territory of an endoscopist. So it has markedly increased the ability of the endoscopist to go to another previously inaccessible organ. And moving forwards, nowadays we can even perform EUS guided drainage of the GI tract. So for example, in a patient with avian limb obstruction, we can perform avian limb drainage. And also we can perform a gastrojejunostomy as well. 2 years ago, we've published this consensus guideline on the optimal management of interventional EUS procedures from the So this is the first guideline published by any endoscopic society on interventional EUS. And we have gone through a very rigorous approach in terms of setting up the guidelines. I've spent almost 5 years in various stages of this guideline. And in this guideline, we focus mainly on 4 procedures, including pseudocyst drainage, biliary drainage, pancreatic drainage, and also celiac plexus ablation. And the guidelines not only cover the procedure, but we also cover indication, pre-procedural planning, post-procedural planning, and also training. So if any of you are interested, please take a look. We also plan to have an update on this guidelines soon. We plan to include more procedures like gallbladder drainage, wall of necrosis, or even GJ. So pivotal to the development of all these US drainage procedures is the development of US specific stents. So I think some of you may have heard a very famous stent called a Axios. This can be classified as a dumbbell type of stent. These dumbbell types of stent, you can see, have a characteristic shape where both ends of the flanges looks like a dumbbell. So the flanges are much larger in diameter. It also serves to prevent migration of the stent. The other thing is the stent lumen is usually quite big. So Axios is now up to 20 millimeters. Spexis is 16 and Nagi is around 10. So with these type of stents, not only it makes the anastomosis more secure, also the delivery system is also now, many of them are cautery enhanced, which allows a single stepped placement of these stents. Tubeless type of stents is also available for US drainage. These are mainly used for HGS or CDS. You can see these stents have a characteristic partially covered design. So this part is uncovered, which allows the stent to anchor onto the liver, into the bile duct, and the cover side is to bridge between the liver, the bile duct, and the duodenum. There are even more many newer devices coming out. For example, this is a steerable needle, which is coming out from Medtronic, which allows the endoscopist to change the direction by turning the needle around, so which helps to guide the direction of the guide wire. These are the cautery enhanced delivery system. This is a hot Spexis, which has come out as well. This is a Axios hepatical gastrostomy or CDS stent. You can see the trademark Axios dumbbell on one side, and the other side is a covered to uncovered metal stent. Again, designed for use in HGS or CDS. So the development of these EA-specific devices are very important because it allows performance of novel procedures and reduces the difficulty of the procedure. It also reduces the risk of leak or complications. It also helps to shorten the procedural time as well as decrease the learning curve of the procedure. In terms of interventional US, current indications, PFC, I think now endoscopic drainage is the standard, which includes both pseudocysts as well as wall of necrosis. For biliary drainage is mainly indicated in patients with ERCP. Gallbladder drainage is indicated in patients with at very high risk for cholecystectomy. PE drainage in patients with a PD or PJ stenosis. Celiac plexus intervention mainly for patients with intractable tumor pain secondary to celiac plexus infiltration by tumor. Of course, these procedures can be developed more in the future, and many new procedures can also be considered. In biliary drainage, there's a lot of studies that has been done, and some are still ongoing, which are looking at the potential of US biliary drainage to maybe replace ERCP or become the primary method of drainage. For gallbladder drainage, we know that I performed a study randomized control trial comparing US versus percutaneous. So US has a lot of advantages. For PD, it may replace enteroscopy or surgery. For gastroenterostomy, it can be an alternative standing. And tumor ablation may help in terms of cyst and tumor control. And also a very interesting subdivision of endoscopy is the endohepatology. So now we also have the ability or devices which allows us to assess the degree of cirrhosis, mainly by measuring the portal venous pressure gradient. So for PFC drainage, I think this is becoming or has become standard in many centers. So I'm not going to go through too much of the background. I think there are a number of issues that still needs to be resolved. Firstly, whether the newly available metal stent actually provides additional advantages over plastic stent, whether the role of PPI versus H2O2 or H2O2 in terms of reducing the need of necrosectomy. After drainage, what is the timing for necrosectomy? And also some newer device, which is not really designed for the US, but is related, are devices for necrosectomy. So this device is called the EndoRotor. It was previously designed for mucosectomy. So you can see that is a rotatable device. So now they are using this device to perform necrosectomy. You can see all this black, bluey stuff is necrotic pancreas. The tip of the device, you can see it's a kind of like a cutting blade, which cutting rotor, which cuts around continuously. And inside the lumen, suction can be applied so as to suck out all the necrotic debris. So I've seen a few cases. It seems to be quite effective. Of course, you need to be careful not to suck in any vessels or anything like that. But it seems for those who have done necrosectomy, you know that sometimes the procedure can be very cumbersome. So it seems like the device works very well in these sort of cases. In terms of USB drainage, I mentioned a very hot topic right now is whether USBD can potentially replace ERCP. So the main rationale is that in USBD, the stent is placed away from the tumor. So this may potentially reduce the need for reintervention or reduce the risk of tumor ingrowth. So there may be prolonged stent patency, reduced procedural time, and there's no risk of pancreatitis. Of course, to perform USBD, you need a technical expertise. There's a risk of complications, as well as the need of dedicated devices, which may make the procedure more expensive. So this is a patient with a hepatogastrostomy. This is being the US is placed in the stomach. You can see a dilated left intrahepatic duct. So puncture first with a 19 gauge needle. You can see the patient previously had a duodenal stent. That's why they cannot perform ERCP. After puncture with the needle, a guide wire is passed down. And then we exchange the device. So this device is a single step device, what we call a single step device. So you can see the delivery system in the tip. There is a sort of a dilator. So meaning I do not need to dilate the tract before placement of a stent. So normally we would need to dilate the tract with cystotome followed by a 4mm balloon. So there are at least 2 or 3 device exchanges required. And during device exchange, there's always a risk of complications or bowel leak. So by using this device after puncture, we can immediately change to this dilating delivery system. And you can see the device with a gentle push. It goes in quite smoothly. And then following the guide wire going down. And then we'll open the stent radiologically in the X-ray guidance. So half of the stent is open under X-ray guidance, and the other half of the stent is actually open inside the endoscope. So we believe this way is the safest way to deploy an HGS stent. So after the stent is deployed inside the channel, we will slowly push it out from here. Push it out, stand out a little bit, pull back the skull, push out a little bit, pull back the skull until the entire stent is being pushed out from the channel. So this study published by Asan Medical Center involving 4 tertiary centers in Korea comparing primary USBD versus ERCP. They showed that the technical success is similar, clinical success is similar, but the overall adverse events is significantly less in the USBD group. Reintervention rate is 15% versus 42%, and the stent patency was 63% versus 36%. In the USBD arm, obviously there were no patients with pancreatitis, and in the ERCP arm there was 14.8%. So this study is promoting USBD as a primary method of draining the bile duct in patients with unresectable tumor. So this is the Kaplan-Meier curve showing that the USBD arm has a significantly longer stent patency as compared to ERCP. My main complaint is that seems that the stent patency in the ERCP arm is a bit low for this study. So we are now performing a randomized trial, multi-center study. We're up to around 140 patients recruited already. So hopefully we can also try to answer this question as well very soon. So as I mentioned, US drainage procedures is a way to drain the system, but it's also a way to access the system. So this patient actually had a post-Whipple complete hepatojejunostomy stenosis. A PTBD was inserted. We first converted to internal drainage with HGS because the patient really didn't want the PTBD. And then afterwards, we used the hepatogastrostomy as a means of accessing the bile duct. So I used a ultra-thin nasal endoscope, go inside the bile duct. And once I was inside the bile duct, then I tried to look for the anastomosis, which you can see is actually completely stenosed. So I tried to insert the guide wire, but it wouldn't go in. So afterwards, I had to use a needle because I can see from air cholangiogram, the jejunum is very closed. So I tried to puncture the anastomosis and try to get into the duodenum. And eventually I was able to see contrast in the jejunum right there. So afterwards I was happy. And then I inserted a 018 guide wire inside the jejunum. Followed by dilation of the tract with the cystotom. So you can see some sutures from the previous hepatojejunostomy. And eventually the cystotom went in, and then I dilated the tract and then placed one double pigtail plastic stent. So eventually, after a few sessions, the patient was dilated to around 8 millimeters. I placed 3 double plastic stents, and the patient after a year was stent free. For gallbladder drainage, again, this procedure is becoming more and more popular, mainly indicated for patients with acute cholecystitis. So this is one of the HOT system, in which the tip has a cautery tip, and then again allowing the direct puncture and opening of the stent at the same time. So US gallbladder drainage, as mentioned in Tokyo guidelines, is one of the alternative to PTBD, PTGBD in patients at very high risk for cholecystectomy. So mainly in institutes where there are high volume institutes that can be performed by skilled endoscopists. We have published a meta-analysis in endoscopy comparing US GBD versus percutaneous cholecystostomy, 5 comparison studies, 495 patients. Technical success rate and clinical success rate were similar. Total adverse events rate were less with EGBD. Hospital stay was less, shortened in US GBD. Recurrent hospital admissions reduced, recurrent reinterventions was also less in US gallbladder drainage. So this is expected because with percutaneous drains, the patient often come back with a blocked tube, dislodged tube, all sort of problems. And also patient in general do not like these external tubes. We have also recently published the results from this randomized trial, DRAG study, comparing US versus percutaneous cholecystostomy. So in the US arm, we showed that the 1-year adverse events rate was significantly less, 25% versus 77%. Recurrent cholecystitis was also less, 2.6% versus 20%. Reintervention, again, less in US GBD. Unplanned admissions, and also 30-day adverse events were all in favor to US gallbladder drainage. So right now in management of acute cholecystitis, I think for surgical candidates is, of course, laparoscopic cholecystectomy. Marginal candidates, according to the chocolate trial, is again laparoscopic cholecystectomy in patients which have multiple comorbidities, which you don't plan to perform cholecystectomy. I think with the DRAG study, we can conclude that US GBD is the treatment of choice. Again, after gallbladder drainage, the stent actually allows us to act as a portal for us to enter into the gallbladder. So a new procedure known as perioral cholecystoscopy has been invented. So we have published the results of perioral cholecystoscopy. In 25 patients, 29 cholecystoscopy, we could perform all sorts of interesting stuff like MBI, confocal, EOS, or even endocytoscopy. The overall stone clearance rate in after cholecystoscopy is 88%. And these are just some images from the cholecystoscopy. You can see a sort of multiple papillary projections inside the gallbladder. This is a patient with a necrotic gallbladder. I think the patient has suffered from a very severe cholecystitis. So you can see a lot of necrosis inside the gallbladder. This is interesting. This is a patient, elderly patient, which pre-drainage CT didn't see anything. But when we went inside, we see a incidental cancer of the gallbladder. So it was an elderly patient, so surgery wasn't planned anyways. But again, this is a very unusual site. This is a patient with a stone, big stone in the gallbladder. It's so tough that it broke 2 of my BML. So eventually I had to use a laser lithotripsy to break it down. So these are very interesting adventures inside the gallbladder. And this is now possible. In terms of US gastroenterostomy, now we can perform a US guided GD. It's not a GJ because we're usually puncturing or draining the 3rd, 4th part of the duodenum. So thanks to this device, it's called a double balloon occluder. There are 2 balloons in the device, and water can be filled in between to allow performance of a gastroduodenostomy. This is the configuration is of course very different from our usual surgical GJ. This is an interesting patient. You can see right here, all the small bowel is actually on the right side of the patient. So it's an undiagnosed malrotation, and the patient had a gastric outlet obstruction. So before the procedure, I was doubting whether gastroenterostomy was possible. So, but with the double balloon device, I was able to distend the small bowel. So the first part is still to cannulate the stricture. And then I will remove my scope. And then I would insert a double balloon occluder. This is the tip of the device being pushed in. The tumor is here. You can see some resistance. The first mark is the mark of the first balloon. And this is the second mark of the second balloon. So the two balloons would be inflated. And then a segment of bowel in between the two balloons could be distended and filled with water. So one balloon here and the other balloon here. The tumor is around here. So this is one balloon and the other one here. So after inflation, it would occlude this segment of small bowel. And then we can inject water in between the two balloons. You can see a very distended small bowel right there. So it's kind of like a drainage of a pseudocyst or a gallbladder. So you can just go in direct puncture, burn the way through, go inside, and then deploy the Axios. And the gastroduodenostomy would be finished in 5 minutes. Okay, distal flange open. And then we oppose the two lumens by pulling on the Axios, followed by deployment of the proximal flange. So US guided gastroenterostomy, we will perform a randomized trial on comparing a US guided GD versus duodenal stent. And again, hopefully you can show the benefits of this procedure. As mentioned previously, now there's a new subdivision of endoscopy known as endohepatology. So for US, we can also perform variceal surveillance, US guided liver biopsy, portal vein sampling, and also measurement of portal pressure gradient. So this study was published by Ken Chan, showing that by puncturing the portal vein, we can measure the portal venous pressure. So by puncturing the portal vein, usually we would perform it in a transhepatic manner. So the needle will first go through the liver parenchyma and then enter in the portal vein. So the risk of bleeding is minimal. In terms of radio frequency ablation, nowadays this is a very hot topic, but this is not the only device which we can use perform a US guided ablation. We can use alcohol, we can use HIFU, and also most recently, an interesting substance known as OncoSeal. It's a liquid radiotherapy. So it can be up to 100 grays, can be delivered with the injection of this liquid. So this is a patient with unresectable pancreatic cancer. We have a protocol to evaluate the use of efficacy of radiofrequency ablation. This is a tumor. The needle will come in from here. So this is a pre-procedural contrast imaging. We want to see the viability of the tissues in the tumor. And then the needle will be inserted. There is a needle. And during radiofrequency ablation, you will see some bubbles coming up right there. So the needle is a needle with a water coolant in the tip. And it can be used to cause a temperature, raise in temperature to 60 degrees for ablation. So multiple ablations can be performed along the track of the needle. And then if we need, we can repeat the ablation around the tumor as well. Of course, the risk of this procedure, most worrisome risk is pancreatitis. Somehow for pancreatic cancer, I think the risk is lower because these patients already have a tumor right there, and also the PD is obstructed very early on in the disease. So again, studies are ongoing, comparing the use of, assessing the efficacy of RFA. So hopefully we will know the results very soon. So in terms of the future of interventional EUS, many new procedures coming out, including GJ, tumor ablation, and portal venous interventions. So I think we are entering a period of boom for interventional EUS. There are many exciting new opportunities, but of course we will need more data from randomized trial required to confirm the efficacy. So thank you for your attention.
Thank you very much, Anthony. Really nice lecture, and you showed a lot of potential for the performance of EUS with a lot of different procedures. So I guess from your experience, a lot of surgical patients can now also be treated by EUS. So, for example, like a gallbladder drainage. So, do you think, in the future, what will be the pros and cons of doing EUS guided gallbladder drainage to manage acute cholecystitis, even for healthy patients? Is it possible, or just keep on with the laparoscopic cholecystectomy?
So of course, this is a very controversial area, but it's also very exciting. For US gallbladder drainage, if you have done it before, usually if it's straightforward, you can finish the procedure in 5 to 10 minutes. So as compared to performing lap chole in acute cholecystitis, which usually takes 1 hour, 2 hours, 3 hours, and sometimes you may even need to convert to open. And also there's always a risk of bile duct injury. So in terms of the initial procedure, seems that EUS may be more favorable. But of course, if we are leaving the gallbladder out, then there's always a risk of gallstone reformation. And once the gallstone reform, then we need to see how many patients will actually become symptomatic. So I think from previous data from PTC, I think there was a time where there were a lot of people performing percutaneous cholecystolithotripsy. So they would insert the percutaneous cholecystostomy and then dilate the tract and then clear the stones. So in one of the biggest series, around 300 patients followed up, they clear all the stones and then follow the patient up to 10 years. So I think in that study, only around 5% ultimately required cholecystectomy. So of course, it really depends on who sees the patient and whether you offer this sort of procedure to the patient. But I think it will be interesting to see if it would be an alternative to lap chole in these patients.
Okay.
Peter, can I ask a question?
Of course.
Thanks. Anthony, if it's really congratulations for all your good works and all the innovations, and also that your try to create scientific evidence on all the new procedures. And my question is on gastro-J, and you think that what's the potential advantage compared to duodenal stents?
Yeah, so for duodenal stent, I think, of course, we know when compared to surgical GJ, the duodenal stent has more re-interventions required, and also sometimes the functional outcome may not be as good. So of course, we hope that the US gastroenterostomy may be comparable to a surgical GJ. By that, the stent is not placed through the tumor. There may be less chance of re-intervention. But at the same time, we do not need to subject the patient to a laparoscopic or open procedure. So I think that's the main advantage. But of course, there are limitations in terms of anatomy. We need special devices, and we cannot really control the distance of the small bowel from the DJ, meaning we are limited by the distance from the stomach to the closest small bowel. So in that way, we cannot control the length of the GJ, if you know what I'm saying, yeah.
Okay, thanks, Anthony. So for your nice lecture, and of course there are a few more questions follow on, and I think Anthony will reply this on the web.
Okay.
Before I introduce GV, so we have an interesting poll for this ELSA webinar that I wish to share the results with you. And so if you look into the current webinar poll results, you can see that most of our participants are consultants, senior consultants, or junior consultants, so specialists. But we do have 30% of proportion that are residents. So we welcome our younger surgeons to join the webinar. And secondly is how many cases of flexible endoscopy you did every year. So in fact, these are surgeon endoscopists, I believe, because the number of cases varies between the 51 to 100. So mostly performed 100 procedure. So do you perform only diagnostic endoscopy? 40% of them actually perform diagnostic endoscopy, while if you look into diagnostic and operative endoscopy, and also both, and they are in proportion of 30 and 23%. So do you perform mostly ELCP in 48% of our participants, but there are also people doing EMR, less people doing ESD and POEM. So I think I hope that this webinar can help you to gain knowledge about these advanced procedures. And in your opinion, it's POEM superior to surgical treatment, and 48% say yes, and 16% say no, and 36% is similar efficacy, despite so we also know that from the randomized study, the outcome. So, and the last question is, do you think it's ESD superior to laparoscopic gastrectomy? So 62% believe yes, and 17% no. Similar efficacy is 21%. So with that, with a very good, nice background information, I'd like to introduce Professor G.V. Rao. So Professor Rao is outstanding endoscopist and surgeon from Asian Institute of Gastroenterology in Hyderabad, India, and he's been pioneer and leading surgeon endoscopist in a lot of procedure, including pioneer of performing Noakes endoscopic appendixectomy. So GV, please start your presentation, GV. GV, okay, good.
Yeah. Thank you so much. At the outset, let me thank all the executive of ELSA, Philip Chu in particular, David, Sutap, and all actually for the honor of this lecture this afternoon. If you see at the turn of this century, the technical feasibility of an endoscopic appendectomy was shown from our department. Now, this flexible endoscopic peritoneal surgery by pioneers and experts in institutions across the globe took the medical world into a world of fantasy. Everybody seen this and they dreamt of doing these procedures of an endoscopic appendectomy. For some of you who have not seen this video, it is an endoscopic view wherein you get into the peritoneal cavity like what Philip Chu has showed you. You make an access in the stomach, get into the peritoneal cavity. And then once you're in the peritoneal cavity, you dissect out this appendix. And then once at the end of the procedure, this entire appendix is brought out to the mouth. Now, this one procedure seems to have changed the entire concept in which surgery can be done. And subsequently, there are a lot of data to show that similar endoscopic cholecystectomies can be done. But something surprisingly, it was something similar to the Apollo adventures or the Apollo landing on the moon. Now, the consistency and repeatability of these procedures was questioned across the globe. And this obviously is basically because a lot of limitations. We jumped suddenly from the lumen, we started doing polypectomies, and we jumped from the lumen onto the peritoneal cavity. The jump was so huge without proper understanding of the anatomy and without proper equipment available for these procedures. Now, the third space has come in a big way, and it's an unexplored space. That is what is the interface between the endoscopists and the surgeons. The understanding of the third space and the very therapeutic options that are available in this has led to a new science, a new topic, and a new specialty called third space endoscopy. And we started doing these procedures like what Philip has shown you, EMR, ESD procedures, to lesions which can be picked up from the third, fourth layer of the stomach. Now, there were several limitations of this endoscopic surgery, and basically because of this, hybrid nodes or hybrid node procedures came in, and this basically because of certain limitations and also availability of the equipment. Now, this hybrid endoscopic procedures was the first term was first coined by Roddock way back in 1937. Subsequently, the terminology changed from various intraluminal laparoscopic surgery, endogastric surgery, laparoscopic surgery, or endoluminal surgery, or we call it as lap endocollaborative surgery. All these are the similar names, and then it is also called as laparoscopic endoscopic cooperative surgery. Now, there are umpteen number of options available for this. This hybrid endoscopy, hybrid procedures that you're talking about. It could be because of hybrid instrument, wherein use flexible instrument, or a rigid instrument, or use a combination of rigid and flexible instruments, or it could be a hybrid access, where you have a dual multiple access, or you're having an endoscopic access and a laparoscopic port. All these constitute some sort of a lap endoscopic cooperative surgery. Now, this is a cooperation between endoscopists and laparoscopic surgeons. It's a win-win situation. It is not you lose some, you win some, but ultimately it's a win-win situation for both the physician, the endoscopist, and the surgical community. Now, a lot has to be understood when you're talking about this new laparoscopic endoscopic hybrid surgery, and you're supposed to know about the interface between the endoscopy and surgery. Now, basically, as I told you, endoscopists traditionally limited their access or interventions to the luminal side, and surgeons have limited purely onto the pleural side or onto the peritoneal side. Now, what has happened with the recent advances, recent innovations in techniques, endoscopists started moving from the lumen outside, and there are a lot of interventions from the peritoneal cavity onto the luminal side. So there is a lot has been happening in the last decade or so. So we need to understand a lot of things before we venture into this new era of laparoendoscopic surgery. The question that are repeatedly asked is conventional anatomy applicable in current day endoscopic and laparoscopic practice. Now, we all as clinicians, we claim that we know the Gray's anatomy inside out. This is a famous mnemonic that people keep saying, that we have read Gray's anatomy inside out, and we know the anatomy inside out. But surprisingly, this is a myth. Gray never wrote the anatomy inside out. He wrote the anatomy outside in. The entire anatomy, whatever we know, is the anatomy that we look at going from outside to inside. So the conventional anatomy, so if you see these are the abdominal organs. Now, if you see, whenever we're doing any procedures, we're going from outside to inside, or from the lumen from the peritoneal cavity into the gut lumen. But the newer procedure, the third space endoscopy you're talking about, a hernia on the laparoscopic side, you're going from the peritoneal side onto the skin, and also we have other endoscopic procedures wherein we started going from the lumen into the peritoneal cavity to do these procedures. Something like this. Endoscopy is from serosa to mucosa. Endoscopy is from mucosa to serosa. If you see, this is what happens. And this is the endoscopic view of the esophagus that you talk about. Traditionally, we just know this is the anatomy. We talk about 3 o'clock, 9 o'clock, 6 o'clock, and 12 o'clock positions. But we also supposed to understand what is outside this lumen, so that we can do these procedures, the transmural procedures, very effectively without causing any complications. It is like what happened when we traditionally, the open inguinal anatomy is totally different from the laparoscopic inguinal canal anatomy. We have relearned the entire anatomy when we started doing laparoscopic inguinal hernia. Similar way, I think we have to rewrite the entire anatomy for these endoscopic procedures, wherein we go from the lumen onto the peritoneal side. This is the luminal side on the left side. This is the serosal side. But what we need to understand is the different layers of the stomach and the lymphovascular structures, and how we have to gain access into the peritoneal cavity without much morbidity and mortality in these procedures. So what we have to do whenever we are doing this third space endoscopy or advanced endoscopic procedures, or these endolaparoscopic procedures, is to unlearn the outside-inside anatomy and relearn the inside-out anatomy. This is very, very essential. Without understanding this anatomy, I do not think we should venture into these advanced procedures, so that we avoid any major catastrophes during these procedures. This is basically because there are several anatomical structural vascular variations that we encounter. We all read about this when you are doing our convention during our medical school. Like this, actually, there are limitations. Actually, I can show you whenever we have an obese patient, the heavy fat limits the distension of the stomach as compared to a lean patient. Now, this is basically because of the heavy momentum, fatty momentum, which limits the distension. Likewise, the MIS, the endoscopy, the third space endoscopy or laparoscopy is all about working in positive pressures in potential spaces. Now, is conventional surgical physiology applicable in current day clinical practice? Now, if you see, this is conventional surgery wherein the outside atmospheric pressure is equivalent to the peritoneal pressure. So this is what we have been doing. Once we started doing laparoscopy, we increased the intra-abdominal pressure and we relearned the entire physiology of this so that we can deal with these patients very effectively perioperatively. Now, when we started doing endoscopy, the luminal pressure is more. And when we started doing third space endoscopy, you can see the pressure in the lumen and also the pressure in the third space is very high. And we started doing endolaparoscopic collaborative surgery. You can see there is increased pressure in the peritoneal cavity, increased pressure in the third space, and increased pressure in the gut lumen. So this is very, very important to understand because a lot of physiological changes occur and we have to work very closely with our anesthetists so that we do not have any perioperative problems during these procedures. So the endoscopic carbon dioxide insufflators are not still fully automated like we have on the laparoscopic side. The semi-controlled high pressure delivery of carbon dioxide into the third space tight compartment combined with high pressures in the two compartments causes physiological changes. And this we need to be aware and we have to require close monitoring during the entire surgical process. Likewise, cross-sectional imaging for advanced endoscopic procedures, we have the sagittal plane, we have the transverse plane or the coronal planes. As far as this is what we do, transverse and coronal sections for esophagus are very good because we know we'll be able to absolutely know the relations of these various pathologies that we encountered during these procedures. These are very good. But when we start going into the abdomen, the sagittal sections are ideal for advanced endoscopic procedure. You can see this. This is the direction in which the scope goes, and you can see that very clearly the direction of the pathology and the direction in which we traverse. Especially suppose if you're talking about wand, like what Anthony Theo has shown you, sometimes you get these wands which are extending across the lesser omentum onto the anterior side. It is very, very difficult to predict this. These sagittal sections go a long way in planning for these procedures. So these sagittal sections are ideal for advanced endoscopic interventions, especially in the stomach, because of various structural and anatomical abnormalities that we encounter, and also to look at the adjacent visceral structures, blood vessels, and also look at the gastric and perigastric collaterals. Let's get on to the bariatric and metabolic endoscopy. A lot has been happening, umpteen number of techniques that are available for obesity and for metabolic therapy. Now, these are all, most of these endoluminal restrictive procedures, the endoscopic procedures are all based on the laparoscopic procedures. The results of the laparoscopic surgery have been translated onto the endoscopic side. We have many of these procedures that have come. And we have this endoscopic sleeve gastroplasty, which is coming in a big way in the management of these patients with obesity. There is data to show that it is being increasingly used in the treatment and it's gaining access into the treatment algorithms. But surprisingly, if you see this endoscopic sleeve gastroplasty is a semi-blind procedure. This is a suturing device, what Philip has shown you. Beautiful device. This is the only device which can show that the endoscopists can be very, very sure that they can do suturing. But surprisingly, what happens is these are semi-blind procedures and most of these sutures that we take need not be full thickness sutures. And it is likely, surprisingly, and very rightly, the stomach is heavily perfused. That is the reason we don't see any ischemic changes in spite of taking these multiple sutures because of the extreme good perfusion of the stomach. And you can see this is the serosal aspect of one of these patients who has undergone endoscopic sleeve gastroplasty. Only a couple of sutures are full thickness, rest of all are not full thickness sutures and just mucosal sutures. And you can see this one of these procedures. You can see This is the video of a patient who underwent the ESG. You can see this. Only 2 or 3 of these sutures are full thickness sutures. And if you see the luminal side, you can see this. Most of these are just mucosal stitches, which looks like some sort of a trabeculae that we see in ulcerative colitis patients. So most of them are not full thickness sutures. This technique has shown that we can do a good endoscopic suturing, but I think we need ways and means to improve this technology so that we get full thickness bites. Maybe we try to take full thickness bite because of the associated complication that can come. Now, this is another patient. You can see this. This is the only 2 bites that have been taken full thickness, and this patient underwent a revision surgery again subsequently following ESG procedure. No, I personally believe, I think we have a good advantage of using this mini laparoscope. Actually, you can use this 5 mm laparoscopes during these procedures as an aid to make sure that you're taking full thickness bites so that any associated complications can be avoided. And also, suppose if we have infrared laparoscopy that is attached to this, maybe you can also check the gastric perfusion as you're doing this. This may not be essential because stomach is heavily perfused. This may not be required. But I personally believe that whenever we're doing this to get a good bite, we can always use a 5 mm scope to make sure that you're getting full bites. Likewise, there are several of these endoscopic procedures that have come, which are purely based on the results of the laparoscopic surgical procedures. All of them have been translated. Now, most of the duodenal endoscopic procedures that are coming in are being used are basically, they mimic the Roux-en-Y gastric bypass, and the results of this have been extrapolated to this. We look forward to this, but these are certainly they look very promising, and they seem to be act as a bridge to surgical intervention. Certainly seem to be the game changers, especially for metabolic interventions. Now this is another indication for this. Actually, this now of late there is a lot of big role for indigocyanine being used for laparoscopic surgeons in every part of surgery. Now, this is basically an intralesional injection of ICG to pick up sentinel nodes so that we pick up this. This is a beautiful thing that has come, wherein you're combining endoscopy and laparoscopic procedures together. You can see this. This is how you inject indigocyanine intralesionally, and you're able to pick up the sentinel nodes, and then we do so. The surgery is basically planned based on this finding that you see on infrared laparoscopy. Likewise, now endocytoscopy is used during diagnostic laparoscopy. Here we're using an endoscopy in a patient with peritoneal metastatic disease. You can see this. We are doing it's a real-time in vivo histology wherein we are able to see the tumor emboli in the blood vessels. So as compared to a frozen section, this is a real-time image, and you can see this dynamic images of histology that we see we have never seen before. So this is a combined endoscopic and laparoscopic procedure again, which is going to be a game changer in future. Now, this is again, though it's not a laparoscopic procedure, it's chronic pancreatitis with a patient with a stricture in the head. We tried to do a head coring procedure in this patient. Surprisingly, we found a stricture, and then we stained it with methylene blue and put in the cytoscope. And you can see this is the malignant stricture in this. Likewise, we have this now IPMN. There is increasing role of pancreaticoscopy, especially in patients undergoing IPMN. Pancreaticoscopy is coming into the algorithms of management of patients with IPMN. Be it the lap Whipples or open Whipples, centers have started doing laparoscopic Whipples for with good expertise. Here is one such patient who underwent a Whipples procedure, and you can see this after transected. We put in the scope into the remnant pancreas, and we picked up an additional lesion a centimeter away from the transected margin, and this is the revised specimen again. So you can see this during this laparoscopic or open Whipples, actually intraoperative pancreaticoscopy is becoming more and more popular. This is used basically to pick up skip lesions, which are not picked up from conventional cross-sectional imaging. Gastroesophageal reflux disease, actually, umpteen number of procedures have come. Actually, they're all in clinical. I personally feel they're all still in clinical trials. We just have to wait for this. Absolutely, as in today, we are still awaiting for an ideal technology that can be compared to laparoscopic fundoplication. We have good results that are coming up with various technologies that are in the market, but we still have to wait for long-term results of this before we can say that they can completely replace or they can be equal to laparoscopic fundoplication. Likewise, actually, there are several of these procedures which cannot be done endoscopically, like this denture, which was impacted in the esophagus, or this a large esophageal diverticulum. These sometimes it is very difficult to do it endoscopically in spite of every possible expertise that we have. In these circumstances, a combined laparoscopic procedures are very, very useful, and this expertise makes these procedures very more amenable. More of these patients can be salvaged using these procedures, and you can see this. This is how we can extract this impacted denture, and likewise the diverticulum can be completely excised using a complete endoscopic under endoscopic assistance. Achalasia cardia poem, actually Philip has given a beautiful and Jimmy has given a beautiful review of the entire thing. Actually, we are totally convinced that myotomy can be done endoscopically with an excellent view and beautifully. I mean, there is no comparison. We can show that the myotomy is absolutely as similar to what we do on the surgical side. Biggest disadvantage of the biggest drawback of this laparoscopic or endoscopic poem procedure is basically that a significant number of these patients seem to have gastroesophageal reflux disease. Now, whenever we are doing a laparoscopic procedure, we always do a partial fundoplication to overcome this, but this is not possible as in today endoscopically. But there are ways and means because there is an initial editorial thinking that reflux could kill the poem procedure, but no, poem F has come in a big way. This is still in infancy. We just have to wait for the long-term results before we can say this can be done very, very safely. But yes, it can be. It is shown that we can do some sort of a fundoplication endoscopically. So, though poem has equal efficacy to laparoscopic Heller's myotomy, now there is the reflux that is associated with poem is of concern, and we need to identify this group of patients who will develop reflux and maybe be an anti-reflux procedure. So post-poem reflux, we have three options: poem plus laparoscopic fundoplication in the same admission. Absolutely, I don't think this is advisable, because if you have to do, we can do a laparoscopic procedure per se. Now, poem followed by laparoscopic fundoplication, yes, this in patients who have reflux. It is not that every patient has reflux. Some of these patients who are not manageable with medications, who require some sort of an intervention, yes, poem can be followed by a laparoscopic fundoplication. And poem plus endoscopic fundoplication, I think we'll see more and more of this in future. We have to wait for this data to come in before we can say that these patients can be done totally endoscopically. So as in today, in our center, what we traditionally believe is poem, follow up this patient with medication. If they have significant reflux, are not able to manage on medication, I think these are the patients who require some sort of a fundoplication procedure. Third space endoscopy, yes, it's a big new area in endoscopic arena. And this is basically because we have better understanding of subepithelial tumors, which are being increasingly detected. We know better knowledge of their biological behavior, and segmental minimally invasive resectional techniques based on sound oncological principles have been developed, and there are better functional outcomes and faster recovery. And so umpteen number of these procedures have come. I think Philip has already shown you all these procedures. I'll show you a couple of these. Now, these procedures basically tailored management based on the location of the tumor. It is not that the same procedure can be done for every single SCT that we see. These have to be tailored based on the position, and there is a lot of data to show that these complete resection can be achieved with absolutely very, very minimal complications in these procedures. A lot of data from across the globe to show that endoscopic resections can be very effectively done. In areas where it cannot be accessed completely endoscopically, we can do a combined endo and laparoscopic procedure, like this patient with a GIST at the G junction. We put in a PEG catheter, and through the PEG catheter, we passed a rigid harmonic scalpel and excised this under endoscopic vision and extracted this specimen endoscopically, and subsequently pulled out this PEG catheter. So this is basically a combined endoscopic and laparoscopic procedure. Likewise, under endoscopic assistance, we can do several of these resections can be done. Sometimes it may not be possible to see these lesions on the endoscopic side, then on the laparoscopic side. So we always require some sort of an assistance on the endoscopic side to localize these tumors and do these procedures. Likewise, Philip has shown you a full thickness resection. Yes, full thickness resection can subsequently be totally be sutured endoscopically using the suturing device. But wherein the expertise is not available, I think these are the patients who require a laparoscopic assistant, a combined assistant. You do a full thickness resection, and once you've done a full thickness resection, this can be closed laparoscopically. So this is the big advantage. But I'm sure in the days to come, with increasing expertise on the endoscopic side, a laparoscopy can be avoided in this. And you can see this full thickness resection. Philip has shown you a lot of data, good results, excellent results with minimal complications. Likewise, we have this lot of these procedures which can be a lot of these SCTs which require some sort of an endoscopic assistance. Like you can see this is a huge gist that can be that is being resected and endoscopic assistant. Subsequently, we check the integrity of the thing, make sure that there are no leaks, and make sure that we are getting adequate margin. Likewise, in this patient, actually, we open the stomach and then get into the gastric wall, do a full thickness resection, and subsequently close the defect laparoscopically. So these are some of these examples, and there are a lot of data to show that complete resection is possible using these combined techniques with absolutely zero mortality in these procedures. So you can see this, there are several of these new procedures which are based on the type of the SCT that you encounter. Now these lesions are absolutely very good for endoscopic resection. These lesions require slightly more expertise. Now these are the lesions which require some amount of caution, and these are the lesions which require a combined endos and laparoscopic procedures so that this can be done very effectively. Likewise, early gastric cancer, this has been shown very effective initially. Now you can see this is how you resect this under and you verify the tumor location, orientation, and we provide assistance, and any adverse events can be addressed during intraoperative, during this procedure. So likewise, now this is a neat procedure that is seen actually, wherein we do a combined endo and laparoscopic procedure. We have submucosal injection has been done, and on the laparoscopic side, we can see that this is how you mark out this entire lesion, and then you do a seromuscular incision from the laparoscopic side, and once you have done this, you invert this entire lesion inside using these seromuscular sutures, so that this lesion gets inverted into the thing. And as we're doing this procedure, maybe we can put some Surgicel to make this lesion very prominent. And once this becomes very prominent, this can be very effectively excised endoscopically. So this basically avoids any spillage of the cancer cells into the peritoneal cavity. And this has been shown to be of great promise, and we are getting increasing number of publications which show that these procedures can be done very safely. And there is some data which came as early as 2011, wherein they said endoscopic full thickness resection and laparoscopic lymph nodal dissection can also be done. This, I think, is very promising. I think in the days to come, we'll see more and more of these procedures. And transoral mediastinoscopy is another procedure that is becoming, might come in a big way into clinical practice. Initial results with animal experiments are quite encouraging, and we'll see more and more of these procedures. And as I told you, third space is a new modality and a new science and a new specialty by itself, wherein umpteen number of these procedures can be done. And in the near future, we'll be seeing more and more of these futures. This is a flexible endoscopic robotic system. Philip had shown you, done with the help of Singapore National University Hospital and along with Prince of Wales Hospital. This is the first ever time we did this procedure. This has shown that the procedures can be done very fast, and combining this with a rigid or a conventional robotic system could further enhance the results of some of these cases. And we look forward to combined flexible robotic system and also the rigid robotic system in future. Now, this way back almost in 2002, 2003, when we initially started doing these advanced procedures, when we were talking about these advanced procedures, one of the very senior scientist, one senior engineer has given this diagram to me, showing that, telling me this is the sort of scope that you require to do all these procedures. You can see this was drawn way back in 2004. And more and more of this newer equipment seems to be coming into clinical practice. We need to deconstruct the entire scope that we have, and we need to have newer scopes like this, which could change the entire management in way in which we deal. So we need industry support and also superheroes to come in a big way to do these procedures. We need newer modalities for access creation and safe closure of these access. We require newer energy sources which can be used on the endoscopic side, and we require newer dissection and extraction techniques that can be used for all these procedures so that these procedures can be done very effectively. So we need all these people from across the globe. We need to come together for an holistic endoscopic laparoscopic interface. To conclude, endoscopic laparoscopic technologies are rapidly evolving. Many of the endoscopic procedures have evolved over surgical rationale. The science behind the surgical techniques led to better understanding and led to the development of innovative hybrid procedures. We need to relearn anatomy physiology applicable to emerging procedures, especially for third space endoscopy and endolaparoscopic surgery. Endoscopy have replaced some, aided some, competing with some, and complementary to some surgical options. Endoscopic assistance has improved surgical outcomes and vice versa. I'm sure endolaparoscopic surgery is a big specialty by itself. So when notes came in, you can see this, because of the lack of equipment, lot of technology, people thought this would go away. There was a lot of depression, confusion, crisis. At a stage when entire thing, people thought it would no more a viable option. But again, third space, newer interventions into third space endoscopy came in a big way, and people started accepting these procedures, and we have these hybrid procedures that are coming in a big way. And I'm sure in the days to come, we'll make true notes a reality from this hybrid endoscopy. So the future is going to be from open surgery, we went to laparoscopic surgery to MIS. So from flexible endoscopy, you've seen various innovations that have been done by Philip and also by Anthony Theo. So I think we'll have a totally new specialty that is going in to come, wherein we have people who are trained in flexible endoscopy and laparoscopy who are going to make this specialty very, very popular. This is not only the specialty will become popular, but this will decrease the intervention, the degree of invasiveness, and also I'm sure it will improve the morbidity, mortality associated with these procedures. I'm sure the future is going to be pure tech surgery. It's a combination of endoscopic and laparoscopic surgery. For all those people who thought it's a fantasy, I'm sure it's no more a fantasy. I think it's a reality, the reality coming true. I'm sure we've lived this age, and I'm sure in the days to come, we'll see this becoming reality. Thank you very much once again for the hearing. If there are any questions from the thing I'll be able to take, I'll check the questions from my side.
Thank you, GV. Very excellent lecture and inspiring. So I hope that we have also invited renowned expert in the field as a panelists for comments. So perhaps firstly, I'd like to invite the president of ELSA, Professor Sutap from Thailand, to give some comment. Sutap.
Thank you. Hi, GV. Wonderful as always. So the advances of endoscopy is always one of the most interesting field that everyone should be following. GV, thank you very much for showing the advantage or advances of the technique. So I believe that the final slide that you've been showing, I think that's one will be soon in the future, because I can see all the panelists, Jimmy, Anthony and Philip, you are there to make it happen very soon. And what I would like to share is that I think we cannot think that we will leave the surgical endoscopy out of our hands. So everyone should be taking the surgical endoscopy. So DV, so how long you think that it's going to be, very soon in the future that we're going to have something that is very, very much interesting that you've been showing at the end of the slide. Thank you.
Yeah, Sutap, actually, the way it looked, initially it looked very futuristic. It is purely an industry-driven and driven by the enthusiastic endoscopic and laparoscopic surgeons. So the energy levels on the surgical side, endoscopic side are very high right now. The industry is also very keen to develop these things. So I think within the last 5 years, we have seen so many advances in endoscopic ultrasound and so many advances in third space endoscopy, which was unimaginable. I think at this rate, I think the next 4 to 5 years is going to be very exciting. I think we'll see more and more of these interventions.
Thank you. And secondly, I'd like to also invite our panelists, Professor Wei Rang, who is the director of the Taiwan ERCAT, and Wei, please give your comments.
Yeah, thanks, Philip. This was definitely a very exciting and inspiring series of lectures. One that is probably unfamiliar to a surgeon who perform mostly surgery. So I think a couple of comments is like I really agree with the last conclusion of GV. That the future will be combining surgery and endoscopy, and also from Dr. Anthony Teal's talk that interventional radiology, like EUS interventional or percutaneous interventional, all these three combined will create, new procedures, new acronyms every year, and so that's something that as a society we need to prepare our surgeons, our endoscopists, how to reshape the training for them. And some of the procedures may look futuristic and understudied, but I think some procedures are becoming more standard and are becoming a standard practice. So and so we need to, when the evidence is accumulating enough, we need to kind of foresee that prepare our students to be able to perform these procedures safely, like Poland procedures or internal drainage of leakages. So, and one thing maybe one question I ask to our expert speakers when you are doing, of course, there are some conflicts with gastroenterologists when you are developing all these advanced procedures. Like do you also perform similar procedures like ESD and POEM, and the gastroenterologists they also perform, and how do you solve these problems? I think that's one question that maybe a lot of the surgeons, when they try to learn new procedures, they need to face in their institution.
Maybe GV should answer, because the AIG is a combination of surgeon and endoscopist together.
Yeah, I very right actually. But I think we have to, the only thing that I can say is I think we need to know our limitations before we do this procedure. That's the only thing that we have to have. And as long as the physicians and surgeons are working together, I think we'll have very good results. Actually, if it is not a pure endoscopic field or not a pure laparoscopic field, I think we have it. We all understand there's a huge gray zone that we still need to understand. But I'm sure the rate at which we are thinking, we never believed that an endoscopic drainage of gallbladder can be done, feasible, acceptable. But now, it is in some certain indications we started accepting it actually. An endoscopic poem, we never initially people never accepted this. But now you can see that people have completely accepted this procedure. And what Philip has shown you, phenomenal full thickness resections done endoscopically. It's unthinkable actually. Now, I think good suturing device. I think we have a good suturing device that is going to come. I think a lot of things are possible, and some amount of laparoscopic assistance to make it safer. But again, I'm very sure about this, because I just want to tell all the students, because we need to understand anatomy. We learn the entire anatomy. We need to understand the physiology again, because we are doing a completely new procedures, and our anesthetists have to be completely aware what is going on. I think we have to relearn anatomy, relearn physiology to make sure that these procedures are totally done without any complications.
Thanks, GV. And we actually receive participants raising their hand. So I'm going to allow the participant to speak. And one of them is, I think it's Professor S.S. Noor. So, Dr. Noor? S.S. Noor, do you have a question? No? Okay.
Maybe just then. Yeah,
okay.
We can reply them on the mail actually. Yes, actually. Actually, any questions are most welcome. We'd be glad to reply them on the mail anytime.
Yeah, and there's also another one, which is Dr. Muhammad Deva. So, do you want to ask anything? Okay, no, they become silent. Okay. Anyway, so I think we almost time to end the session. So, Professor Lomento, do you have any final words or any conclusion remarks?
Oh, thank you, Phillips, to give me this opportunity. I think this surgical endoscopy today is the reality. We can't say there's a future. And I think Asia is at the forefront because we have people like you, GV, Anthony. When I saw Anthony the first time 4 or 5 years ago draining the gallbladder, I was shivering. But I think now, right, GV? When I saw him doing it, but he was so skillful that I came back and said, Jimmy, why you don't do? So,
EUS is one thing that I didn't learn actually. I think I'm repenting not having learned EUS.
Yes, I think it's a great thing. For Jimmy, for example, in
looks like it's going to be US completely. Actually, I mean the way it looks, I think US is going to play a big role in the all the interventions.
Yeah, I think the combination of imaging, because endoscopy itself is a kind of blind navigation. If we have a GPS or driven by imaging, I think will be a great combination of the two. And imagine, for example, if you are like in a poem and you have an imaging associated with you that help you to navigate, will be amazing. As I believe, for example, combined therapy will allow people like Philip to do more EMR or ESD or any kind of resection, because you can downstage maybe T1 or T2, even T2 gastric cancer. Maybe we can start to do a minimal lymphadenectomy. I don't know. I think the surgical endoscopy is a reality that is moving very far ahead of many other procedures. So this is great to have all of you, and the workshop was great. We have a great attendance. Yeah, you can ask other people who are around. I think I saw a few people, Philip.
Yes. Okay, so perhaps I believe we are almost up to time, and
yes.
Yeah, there's just some question, maybe a final question, like to GV, what is the learning curve from laparoscopic to endolaparoscopic surgery? So I think training is one of the major issue that a lot of surgeons will be worrying. And we are all, the panel, they're all expert surgeon endoscopists and also conducting training courses. So I believe that you can give some highlight to this question, like GV, Sutab, and Wei, Jimmy. So you can discuss about the training of endoscopy for surgeon.
Yeah, basically, I personally, because see, endoscopy is a basic requirement for any surgeon. There is no doubt about it. Actually, there are umpteen number of ways where endoscopy can use. In my department, actually, almost 35% of the procedures require some sort of an endoscopic assistance on table. I mean, I use it to the maximum, be it endoscopy, colonoscopy, or ERCP. But the only thing that happens is actually we require good trained surgeons, or we require a combination. You should have a good laparoscopic surgeon and a good endoscopist. And both of them should work in tandem. I think that is the only way to, actually, I know Prince of Wales has got good teams which work together. We have a good team. Sutap has got a good team where they work together. I think it's basically a combination of these two people, both people who are learned in advanced endoscopy and surgery. It's a teamwork. I mean, I'm absolutely totally convinced it's a teamwork, and it is going to take time. I mean, it is not that it can be learned overnight. I think there is, I don't know, are there any studies which show how much time it's going to take, Philip? No. I don't think there are any studies to show how much time it is. There's no timeline that is given to show that, but I think people have to undergo an advanced laparoscopic course, an advanced endoscopic course, or trained in this, and I think subsequently they're going for these procedures. And absolutely, it has to be a team. It is not that the same person is holding an endoscope and a laparoscope together. It has to be a team effort, basically.
Yes, and Sutab, president of ELSA. So, what would be your view and in promoting surgeons doing endoscopy in the Asia?
Thank you very much. I think we are lucky in Asia that we have the very passionate, person like you, Philip, or GV, Anthony, or Wayne, or even Professor Manto or Anthony. So I think this is what we can inspire from all of you. Those people will be first thing having the inspiration, and then they can start it. Coming to the point of training, I think in our center we have cadaveric training mostly for laparoscopy, but we've been preparing for the endoscopy because we know that you had been showing that the combination should be the not the future, it's now. So we added the endoscopy part, so then we can train with a train in the cadaveric lab. I would think that the learning curve would be shorter. And again, I could not say that how long it's going to be. But anyway, first point is the inspiration. Second point is that getting started with the some sort of training, and then finally, I think with a group of people like you, we will be having a very nice procedure soon. It's going to be a reality. Thank you.
Thanks, Sutab. And I don't know, Jimmy, are you here, Jimmy?
Yeah.
Jimmy So.
Oh.
Jimmy. Oh yeah. So Jimmy, I thought I think I joined your training course for POEM procedure. So you have vast experience in conducting training, especially for this advanced endoscopic procedure for surgeons. So how do you feel about the necessity in this kind of training workshop, and how do you like to conduct training for surgeons in endoscopy?
Well, I think this, very good, important questions. I think safety is not essential. I think adequate trainings, and we always believe in like any surgical skill, we need to be well trained. For workshops, proctorship, and observerships, all these are very important, especially when we venture to new procedures. So that's why we think that really that adequate training is essential before we really practice. We really put into a clinical practice.
Yeah, and I remember. So we actually have kind of collaboration so that in some kind of new procedure, I actually was invited by you to come to Singapore. And I think this is a very good model, so that in Asian we have experts. So if you need some kind of proctorship or spread of the technology, we can help each other and to help building up. But of course, we cannot fly every single time. So preclinical animal model for training. I remember you did a lot of preclinical animal training in POEM before I came to your place and helped you for the first few cases. So I think this is also an important model to learn from you.
Yeah, agree. Thank you. Really appreciate that, Philip.
Thank you. So Wei, how about the training in the ERCAP? So do you have any training course for surgeons to do endoscopy? And what kind of procedure are you targeting?
Well, you know very well because you've come with many times, and we have been doing ESD-MR courses for 5-6 years, and those are attended by gastroenterologists and surgeons. And since 1 or 2 years, we have been doing a more extensive year-long workshop on surgical endoscopy, and those are over the span of 1 year, the surgeons come for and it's targeting specifically for surgeons, and you came for that, and 3 times they need to come, and it's basics of endoscopy, and the second time is ESD, EMR, third time is more advanced ERCP even, and POEM. So and there's also like 100-hour online video content that they need to finish. And at the end, they need the proctorship, the observership. They need to submit a case log. So we kind of combine all the elements into a extensive program. So that one was very successful. We were looking forward to that this year, but unfortunately, things couldn't go as planned. But we continue to every course in that we do in ERCAT, we seem to be modifying it to fit the endoscopy trend, because like in bariatric procedure, we are now putting balloon dilatation, leakage drainage, and suturing, but that depends on the availability of the equipment into our workshop. And HPB procedure is also percutaneous, RFA, as we are putting that into our procedures. And so every workshop that is evolving, and also in our Taiwanese Society and Endoscopy Surgery, we just, I think, 2 weeks ago, we finished our first ever endoscopy for surgeons workshop, and that one was very successful. So I think a lot of the Surgeons Society, we are now shifting our training curriculum to fit this evolving trend that is really all upon us. And I think all the training that need to combine all the experts, and I think that's a great thing. Everybody says we have all the experts in Asia, and we can help each other and to conduct courses, and we just need to redesign them, rethink them. How we don't always need expensive models. Sometimes it's just a simple ex vivo stomach, porcine stomach, and you create a situation like a leakage or a fistula, and then create a model, and you can ask the participant to perform these training very well.
Okay, thank you, Wei. So I believe we have over time. So thank you very much for all the expert presentations. And I think personally, I also learned a lot from this webinar. And there was one question about whether this endoscopic surgery will become the future. I truly believe that it will be not only becoming the future, we will have a much more innovation from the endoluminal side. And that is totally for the benefit of the patient. So with that, I think we will close this webinar, and hope to see you next time in all the following ELSA's webinar again. Thank you. Thank you very much.
Thank you very much. Thank you very much.
Thank you.
Thank you, Jimmy. Thank you, Wayne.
Bye.
Thank you, David. Thank you, Sutep.
Thank you, Jimmy. How is everything in Hyderabad?
Hi, everything is fine. Looking forward. I'll talk to you again off the
Hey, yes, we are organizing the conference.
Yes.
We must plan a session.
Yeah.
Something similar. Okay. We close everything. We close down. Hey, thanks a lot to everybody.
Thank you.
Thank you.
Bye. Bye.
We'll upload on YouTube. Okay, you will get the news.
Okay.
Thank you, Philip. Thank you very much.
Thank you. Bye.
Bye. Bye, Sutep.
Bye. See you later.
Have fun.
Yep.